And I'm going to ask the next speaker to start the presentation, if you'd like. So we've got Sakhile is on next. Sakhile, are you there? Yeah.
Yes, I'm here. I'm here.
Sweet Sakhile, I'm going to let you introduce yourself and take over. And
All right.
with your thoughts. There you go.
Good morning, everyone. My name is Dr. Sakhile Msweli. I'm a research clinical psychologist. I'm one of the sessional psychologists that work with the vets triplets that just presented ahead of me before break. And I work in the East London clinic. I'm also a founding member and a board member for Path SA. So I'm equally as excited as the rest of my teammates and the people that went that worked behind the scenes and putting this together. So I'd like to just thank everyone for joining us, and I'm not going to waste any more time. I'm just going to jump right into my presentation. So let me share screen. And also just to say that I do have load shedding, so I'm doing this on my phone. So you won't be able to see my face as I speak through some of the points that I will be discussing today. Maybe just to give a bit of context. So please do let me know if I do break, because I have been struggling with connectivity issues this morning as well. And I did contemplate at one point recording my session, but given how horrible the network is, I doubted if I was going to be able to email it to the people running the program. So I'm crossing fingers. Please cross fingers with me. So I just want to give a bit of context in terms of where this presentation comes from and where it's nested. So I started working with Rutendo and Naomi at Vets RHI clinic in East London as a sessional psychologist during the height of COVID in 2019. Fast forward a couple of years after, I come to KwaZulu-Natal, where I now work full-time for Department of Health at what looks like a district semi-tertiary hospital, because it is the sort of the largest hospital this part of KZN, of rural KZN, which is not in KZN. And so, because I've had so much knowledges and I was exposed to these working groups, Path SA, I had, done amazing, amazing experiences working with trans and gender diverse persons. I thought to myself, and as a queer person as well, I thought to myself, I already know there is a need for gender affirming healthcare. And so part of how I negotiated coming to the side was to say, well, I want a day a week where I can just focus on gender affirming healthcare. And it seemed like a promising dream in the beginning, because there was a lot of buy-in from my department and sister department, which is psychiatry at the hospital. And there was NGO organization that was based here in this area that was functioning at the time. Lo and behold, they lose their funding, and we completely lost that relationship. Even the individuals that were there, that were sort of liaising with, I couldn't get hold of anymore. And with the few clients that I had seen at the time, where I'm currently situated, I want to say that our relationship at best was peculiar, because there were times where people could come and there were times that people were not making it to their sessions. And of course, some of it I understood, because even now I'm still in conversations around availability of hormones, who could prescribe, who cannot prescribe hormones, which I think is something that we've already touched on a bit, and the other speakers have touched on. So I'm going to quickly move on. I want to set the scene before flying through my presentation. I think oftentimes we underestimate the atmosphere in which we do this work. And what do I mean by that? I mean that even though we have this lovely constitution that protects queer rights, you know, whether or not in terms of sexual orientation or gender identity, what we are seeing on ground level is something entirely different. Has there been improvements? Of course, but still, there are people who still have a quite negative attitudes and ideologies. And when I say people, I don't just mean people in the community, I also mean our colleagues, people that we have tea with, people that we have end of year work functions with. And hence, oftentimes we ask ourselves, why are we experiencing such pushback when it comes to providing gender affirming healthcare within our institutions? I'm taken straight to Bruno's presentation that happened earlier. And I think these are some of the things that we need to be quite cognizant of as we work in these spaces where we find ourselves. Particularly within this context, there is still this rhetoric that, you know, anything that has to do with queerness, be it homosexuality or gender diversity, is un-African, and linked to Ms. Q's presentation about statistics, about the numbers. And that's why I felt it was very important that we have those numbers. And like Alma was saying, because oftentimes there's this sense of, oh, you want the service, but who are you wanting it for? Because there's a level of erasure, queer erasure and invisibility that is there. And Ulanda, when he was speaking earlier on, he spoke about this sort of existing in silence of queer folk and trans folk and gender diverse folk. And I'm reflecting on this because I am seeing it firsthand and I'm experiencing it firsthand where I'm currently based. And where I'm currently doing my work, which ultimately then contributes to lack of access to healthcare. Part of it is that, but my experience also has been that there is a distrust of health systems where there's a long history of re-traumatization of trans persons, of queer folk, when they access healthcare, public healthcare systems. And I want to also add, even in the private sector, we know that there's violations that happen there based purely on sexual orientation and gender issues. And so as I speak to that, I want to say that I'm realizing that in as much as the idea is there and the service is there, and I think we can provide stellar services to our trans and gender diverse folk and queer folk at large at my clinic, but I hadn't at the time taken into consideration the fact that a lot of these people that we see, a lot of queer people, a lot of trans persons, are navigating unpredictable levels of safety within their context. One eye-opening thing happened to me last weekend where I was with a couple of friends. There were four of us, two heterosexual, straight-acting, inverted commas guys, and another queer person that we're with, and myself, of course, as queer as daylight. So we were at the beach, we're having a lovely time. We go to an institution to go get food. I stayed behind because I'd been swimming and I'm waiting, so I couldn't enter the establishment. And they come back so quickly, and I ask myself what's happened, and they say to me, the queer friend of mine that was with the other two very straight looking heteronormative guys has just been slapped on the face. And you know, for me, that was very eye-opening because this is an institution, this is a setting that I'd gone to previously with various groups of people, and we've never really experienced that level of sort of discrimination, and I want to say homophobic assault. And I think a week after that, I'm realizing now the need for us to really be sensitive when working within communities around what is happening within context, because I suppose I want to acknowledge maybe that was a taken for granted reality, which ideologically I'm very aware of, but maybe because it hadn't happened in such a long time, I became desensitized to it. So I want to draw attention to why this is a problem, is problematic in terms of lack of access to healthcare, why that is problematic. And there's a beautiful study that was done by Muller. I'm not going to go into detail with it, but it just sort of highlights from that particular study the levels of depression, anxieties that were reported by the transgender respondents. And in terms of our reality, you know, a number of their participants indicated that they were treated with less respect because of their gender identity, and sometimes you know, were assaulted, called names, and things like that because of gender identity in terms of accessing healthcare. So, and Bruno mentioned something, and I think Kevin added to that, that oftentimes healthcare providers, surgeons, whoever is providing the healthcare service, it is, if I have to do it, I'll do it. But colleagues working within this space or working in these spaces where we find ourselves are not entirely wanting to take up the service of providing gender affirming healthcare, which oftentimes I have to remind people of their ethical duties, because as healthcare practitioners, we are all guided by those ethical duties. And the duty particularly of the principle of justice is very important. And also I want to draw your attention to a study published by Anastasia Thompson around the gatekeeping model. And I know some speakers have touched on, you know, how we want to use a participatory model, how we need to center the trans person within their own story and within their own journey. And there's a lot of pushback, because as professionals, some of which we know, they don't want to dismantle that power imbalance that exists between patient and client relationships. And so some of these things are things that we need to be very cognizant of. I'm also looking at my time, and I know I ramble a lot when I do these presentations. So there's a wheel of power. And for me, I suppose, being in this rural context, I need to be very cognizant that I'm no longer at East London, Buffalo City Clinic. I am in rural KZN, where there's also issues of geographical barriers to healthcare, class issues, educational issues, language and sensitivity issues around understanding of the concepts that we work with. So not all is dire and grim, because there's been a lot of notable shifts. There's the SASA Sexuality and Gender Diversity Affirmative Practice Guidelines, which were published 2017, which have been currently updated. And I think as we continue doing this work, we need those guidelines. The three that I've pulled up, I think, are very important: the non-discrimination, the individual self-determination, and the intersecting discriminations. I think as we engage with our colleagues and partners within our spaces in which we work, we need to also be giving and providing this information. A lot will say we don't know about these things, so that's why we're not doing it. But there's a certain level of, we need to be actively improving our knowledge base as health providers. And I almost cringe when someone is saying, I don't know, so I'm not going to do it. Because then if you are now at a space where you realize that there's a knowledge gap in the service that you're providing, why are you not seeking to improve your knowledge base as a health professional? And you know, with PATSA SA coming in year 2020, and the recent South African HIV Clinician Society affirmative guidelines, so there is information out there. It is readily available. There are people like us, all in this group, who are more than willing to support and provide support to our colleagues who claim ignorance. And so there's really almost little to no room for that anymore. So I agree with Ulanda when he was speaking earlier on, and he was saying we need to center the trans person in their own journey and their own narrative. And oftentimes the issue of narrative is an issue, particularly within rural communities, because as we are making advances as academics and researchers working in this space, majority of our communities are being left behind. We are having our beautiful CPD conversations and symposium. Majority of the information that we talk about does not trickle down to ground level, to townships, to rural context, to people that need to have this information. As Sando was saying, a lot of recipients of our services are not even aware of the kind of services that we're providing. When you ask a person what a psychologist does, very limited number of people will tell you. And you ask a person if they've ever seen a surgeon, a very limited number of people will tell you that they've seen one. So there's an increased need for us to continue sensitizing our rural people within our context using the guidelines, and listening to issues of cultural sensitivities and language. Language, because language is important. It is how we interact with the world outside of ourselves. It is how we interact with ourselves also. So it is very important that as we develop and we change language and ideologies, we bring our communities with, because we may start planning these beautiful interventions, but if they are not understood, they're not going to be taken up, and we're going to become quite frustrated, as I have experienced. So issues of collaborative efforts, I completely agree with different local governing bodies within institutions, but also within traditional leadership, izinduna, abaholi, bendabuko, which are traditional leaders, spiritual leaders, relationship leaders, because people, trans and gender diverse persons, don't exist in silos. We all are a body of community. Batu Pele principles, Ubuntu, all of these African philosophies speak to the fact that we need to move together in knowledge production, in understanding, in providing support for persons that are being affected by issues that we're talking about. And I don't think it is so difficult to do, because just recently we had COVID. No one knew what that was, but even every granny at every corner, at whatever hut, at whatever township, everyone knew what COVID was. Right now, COVID is called ukuvethe ngesiZulu, which is something relatively new. So language develops, people can develop, societies can learn when provided with opportunities too. I'm yelling at myself because I'm looking at the time, and I've greatly surpassed the time that was allocated to me. So there's an awareness of continued participation and saying that we need civil society. I'm echoing everything that was said by the other speakers that spoke before me. So thank you so much, and I'm sorry for eating into so much time. Thank you.